Great. Well, hello, everyone. I'm Jeremy Richmond, and on behalf of myself and the co-chair, Matt Old, of the American Head and Neck Society Reconstructive section, I'm really pleased to welcome everyone together here. I was going to say good afternoon, but it's good morning in some parts and good evening in other parts of the world here. This is the third of 3 Recon Around the World webinars that we've been very excited about. Today, we are traveling to Europe. I want to remind people that we will be going to India on June 1st, and all of this, of course, is in buildup of the big American Head and Neck International meeting in Montreal in July, where we hope to see everyone. So without further ado, I'm going to turn it over to our moderator and host today, Peter Jankalewski, who will be taking us through some really interesting cases and introducing the rest of the team. Thanks, Peter.
All right, thank you very much, Jeremy. Appreciate it. Can you guys see my screen?
Indeed, we can.
Okay, perfect. Sounds good. So just a quick housekeeping ad here for the American Head and Neck Society for our international colleagues. You encourage people to join. So many benefits for membership as listed here. There's discounts for meetings, interaction with international colleagues, access to member profiles and everything on the website, and also access to JAMA, otolaryngology, head and neck surgery. And the website is there if anyone wants to apply. AHNS.info will give you the information you need. Just a quick plug for the international meeting that'll be happening in Montreal in Canada. And that's over the summer, beginning of July 8th to 12th. So hopefully we'll see everybody there. I think it's going to be a great meeting finally to be back in person. I don't think I've been to an in-person meeting in a long time, so this will be really nice to see everybody. So hopefully all of our international colleagues will be there as well. So our panel today is going to be focused on challenging oropharyngeal reconstructions, and we've put together a team from around Europe. We have Dr. Sylvie Testelon from Amiens, France, and we have Dr. Wojciech Olushiński, which I hope will be able to join us from Poznań in Poland. And then we also have Dr. Armando De Virgilio from Milano in Italy. And then we have some colleagues from North America as well. We have Dr. Haiti Cycli from Edmonton, Alberta in Canada. A little bit further south on the West Coast, Dr. Mark Wax from Oregon. Myself, I'm in Florida. I'm in Gainesville, Florida. And then our host, Jeremy Richmond, is from Mass Eye and Ear in Boston. And Matt, I apologize. I didn't mean to exclude you. I didn't know you were on here as well. But Matt Old is also here, and he's from Ohio in the Midwest of the United States. So our cases are going to kind of like this, about 10 minutes per presenter or so, and we'll save the questions for the end. We'll check the chat for questions and make some discussions happen that way. Our first presenter is going to be Dr. De Virgilio from Italy. And so Armando, I will hand it over to you. If there's any problems with your slides, I can take over from mine, but I will stop sharing and then you can continue with yours.
Okay, thank you. Thank you very much. Could you see my presentation?
Yes, looks great.
We can indeed.
Thank you very much. It's a real great and unexpected honor to participate to this webinar, and today I'm going to present and thank you very much for the introduction. So today I'm going to present a challenging oropharyngeal defect. So this is a case of a 69-year-old male with a retromolar trigon cancer, which was clinically staged as a CT4N2B or N3B because there was some suspect about the extracapsular extension of one of the 2 possibly positive lymph nodes. It was a CT4 because of bone invasion with the medullary infiltration of the mandibular bone. So this is the MRI of the case. I don't want to lose too much much time about the description of the tumor. So this patient underwent segmental mandibulectomy with the total soft palate excision with the right modified radical neck dissection, and we plan to reconstruct him with a fibula free flap. So usually we work in two teams simultaneously. So usually I search, especially in the fibula free flap, I search to find at least two perforators if possible, and usually I'm going to elevate a long and thin skin paddle all along the bony part we are going to remove from the fibula. So this is the defect. At the end of the ablation of the tumor, we performed a pre-plating. I'll show you one slide just to let you understand how we do it in a low-cost manner. This is the soft palate defect. As you can see, the nasogastric feeding tube was visible. The palate was entirely removed. Usually we pre-plate the mandible using a 3D model we print in-house in a sterile fashion. So we are able to have this tool it costs about €8 in our institution. So we plate the reconstruction plate through another technique we are going to publish soon. We shape the bone component. Can you see the arrow? The bone component in the of the fibula, and this is the very long skin paddle I was able to obtain at the end of the reconstruction. In here we had two perforators which were able to feed efficiently almost all the skin paddle. So in that case, I thought it was possible to reconstruct all the defect. Our problem was to reconstruct the floor of the mouth, the retromolar trigon, and possibly the soft palate with a double layer reconstruction. So I thought it was possible to use this long skin paddle, the anterior part for the floor of the mouth, the middle part for the retromolar trigon. Then I folded the rest of the flap in order to obtain the anterior wall from one side and the posterior wall with the other side. Of course, I removed the skin from the anterior and posterior wall sides in order to have a complete soft palate reconstruction. This is the mandible reconstruction, and this is the appearance of the soft palate at the end. And surprisingly, it worked very good. This is just a slide to show you that nowadays I'm using the exoscope instead of the microscope to perform anastomosis. I think it's very useful for didactic purposes. We are a university hospital, so it's very useful for the residents and students to observe directly this kind of surgery. At the end, the final staging was PT4 and 3B, and we recommended adjuvant radio and chemotherapy. This is the appearance of the flap 15 days after surgery. Surprisingly, he was able to feed by himself about 25 days after surgery. This is the highlight of the skin paddle we used for the reconstruction, the control after 3 months, very good bone integration. So I wanted to show this case just to let you know that I believe that soft palate reconstruction usually seems very difficult, but this case demonstrates that probably just the restoration of the anatomical structure is is sufficient in the majority of cases to obtain a good oral feeding. Recently, we performed a systematic review and meta-analysis of the literature, and from this forest plot, of course, the data are not stratified by kind of flap. We have a mixture of all the flap published in the literature, and as you can see, the feeding tube dependence of soft palate reconstruction altogether is about 2%, independently from the kind of flap and independently from the amount of soft palate we are going to remove. The problem, of course, is the hypernasality, which has been not studied with the same scale, of course, in all the studies. This is a simplified results, but as you can see, hypernasality was present in about one third of the cases, and velopharyngeal insufficiency was also present in about 27% of cases. So just to show you that according to the literature results and according to my experience, oral feeding is not a big issue after even total soft palate reconstruction. The problem is the quality of life provoked by the hypernasality this patient experience, and the velopharyngeal insufficiency as nasal regurgitation during a complete meal. So thank you very much. I don't know if you have any question.
Well, excellent, Armando. That's great. Thank you very much for sharing that one with us. I don't see any questions in the chat yet, but I was going to ask, I certainly agree with you. It's very important to make sure that the soft palate is well reconstructed. When you have a very long skin paddle like you did in that fibula, I find sometimes the blood supply distal is not always reliable. Sometimes you get a really nice skin paddle proximally, but distally it's not always the case. In this particular case, did you have any issues with any partial flap loss or poor wound healing over time further out with its soft palate?
Thank you for the question. Yeah, of course, this is an exceptional case, and because I had very big perforators. So I think this is not the standard of care for reconstruction of the floor of the mouth, retromolar trigon, and total soft palate. That was just the case to show you that even in extreme situation, it is possible to restore the soft palate. Of course, since we worked in two teams, I had the time also to observe for a certain time of period the reliability of the skin paddle, and of course I sacrificed part of the skin. I'm not sure if there was a partial loss distally because as you could see from the picture, the most distal part was the part I used to reconstruct the posterior wall. So I don't know if I had if there was a 100% survival of the skin paddle at the end. I controlled, but many times in the subsequent days. But you know, after this kind of surgery, you have a lot of saliva secretions, so I didn't understand really. But at the end, the result was really nice. Yeah.
Excellent. One of the guests is asking, if the skin paddle had not been well vascularized, did you have another plan for the palate reconstruction?
Yes, I think at the beginning I thought it was the case to use two free flaps, and my free flap of choice. But I think in general, from this also from this meta-analysis, it's evident more than 50% of soft palate have been reconstructed with radial forearm free flap, because it's very thin and pliable. I think it's the ideal flap to reconstruct it. So if I wasn't able to use that skin paddle, I would go for a second free flap, of course, radial forearm.
Great. Very nice. Well, why don't we go on to the next case? If you can stop sharing your screen, Armando, and then if Dr. Testelon can share hers, I believe she would be next. And she's going to present two cases that extend into the oral pharynx, some very challenging secondary reconstruction. So I will hand over to her.
Okay.
Excellent.
Okay. So, first of all, many thanks to ask me to have some two cases from Amiens and the experience of a small maxillofacial surgery department, and but certainly a great experience because of our interesting part for more than 30 years about reconstruction. And so because of these topics of Oropharyngeal, I find two very difficult case in our hands. And so we hesitated a long time when you receive those people from outside first treatment. The first was a male on 45 and a classical story of cancer of the larynx. And so he benefited from laryngectomy, bilateral neck dissection, and radiotherapy and postoperative follow-up to achieve the best treatment, of course. And hopefully he presented severe radionecrosis of all the soft tissue of the neck, and progressively you see it takes three years, almost 3 years to develop a chronic pharyngeal fistula. And so in the department where I was, they decided to go for classical, also a surgical trial to close this fistula. Of course, the soft tissue were very in bad situation, and we know about the extensive power of the radionecrosis of the soft tissue, and they have to support a severe carotid hemorrhagia during the surgery. And so in emergencies, they take the solution after the hemostasis, of course, to cover just a carotid vessel with the pectoralis muscle in emergency, and they send they wait and ask us to go with this man. So he was referred in Amiens in this situation. Of course, it's a pity because it's no more a situation of after laryngectomy, and so he became anxious and very depression because more than this fistula, of course, the saliva escape in the tracheostomia, and he cannot ever eat and he should support lots of infection of the lungs and the recurrency and antibiotics. And so after there is a very difficult things for him to live in that position, and always with the possibility of a new hemorrhagia. And so we ask ourselves how to do with him because we are now in situation of depleting neck on the right vessels on the right side, and we know about the remaining carotid artery and jugular vein on the left side. So it's more simple things, but after that we have to escape to remove or to go in a strong situation with a soft tissue around. And so our goal was to make a very careful dissection about with the vessel, because we know about the story, and also because we know about the extension, the possibility of extension of the soft tissue necrosis, as is usually occurred. So the solution to close the fistula in our hands was to try to take reliable soft tissue and in one time, of course, and with the possibility close the tube and to bring trophicity with a soft tissue. And at that time, we go for pharyngealplasty with a jejunal, a free jejunal patch, just a patch, because of course we have the solution to take in a tube, but we know about the difficulty of dissection around, and always the possibility to extend the necrosis. And so we take just the patch of jejunum, and with a direct anastomosis on the vessel remain in the right, on the left side. And because of the quality of vascularization of the mesenteric tissue, we could put on it expanded mesh graft, and with that result 2 months on postoperative, and so it became in a new position, in the normal position of a laryngectomy, that is to say, closing of the fistula, a normal breath by the tracheostomy, of course. And you see, thanks to the trophicity of the soft tissue, the quality of the skin graft, only very thin but very secure skin graft. And we have the chance, because go back to his region, and we have the chance to see him again 3 years later with a normal life of laryngectomy. And so we like this solution of jejunal flap, even if it's a little more difficult to harvest the flap, but when it's possible, it could save some critical solution for your patient, and we should think about this solution in specific case, of course. That for my first case, and I can answer your question, of course.
Excellent. Maybe 1 or 2 quick questions right now, and then we'll go on to the second case.
What vessels did you use for your jejunum?
Excuse me?
What arterial and venous vessels did you use for your jejunum?
We take the common carotid, just in 2 times of surgery, with a sort of I don't know in English, to be quick, and it was in a lateral terminal on the vein. Or we usually in our daily surgery we'd like to make lateral terminal anastomosis, then terminal one. Of course, in primary it's easy on terminal, because we have all the branches of the carotid, external carotid artery. But for secondary cases, and we perform each week secondary surgery, because we are reference center for that, and usually we try to do in lateral because of the flow, and we learn after some experience. We know that we think it's better in lateral.
Okay, very good. We'll do with the second case that Dr. Tessalon has.
Yes, I try to take it. Hello. I try to find it. Second one. Chez l'autre. Excuse me. Case 1 second, because it was too heavy to put it to send you. Okay. And so do you see or not? Not yet?
Not yet.
Okay, just a minute. So I go again. Okay. Okay.
Good. Yep, we see it now.
Oh,
But I
okay.
think you
I'm not sure is the first slide.
have one slide back. There it is. You got it.
It's better because if it's not a very easy situation, but one more time, a second cases, and it was, as you can see, a very male for 56, and he had a very huge first cancer involving the mandibles, the floor of the mouth and the part of the tongue, and he go to chemotherapy, and hopefully make a recurrence of this tumor, and some months after, and developed a skin fistula with a rostrum, and also a story of lung adenopathy. So he was finally, after this medical treatment, he was in the surrounding of Amiens, and he was sent in our department because he presented an hemorrhagia, arterial hemorrhagia. So we have to do something, of course, for him with imaging department of with embolization in emergency of the branches of the carotid, external carotid artery, like you see here, and of course it's very useful for him, and but the future will be less positive for him, because we have destroyed a part of the vascularization we will see after. And so we have a long discussion in pluridisciplinarity to decide what to do for him, because now there is no more hemorrhagia, a huge tumor with fistula, and we have to make a sort of palliative surgery, as I can see, to give him a possibility to have not a normal life, but to a life to can have a social life, even if we don't know really with the future of the tumor, of course. And so we do as a pelvic glossomandibulectomy with mandibular removal, first time surgery, to make a sort of a complete removal of the tumor. And because of the past and the future, we decided to go with a latissimus dorsi with reconstruction titanium plate, because it's a sort of salvage surgery. And on the postoperative event presented a lot severe, also one more time, hemodynamic failure with general infection from a candida, mycosis, and so we went to flap necrosis, and so we have this post-operative situation with a very large orostomia due to the quantity of the surface of the defect, of course, we done before, and the titanium plate exposure, the vessel exposure, and large orostomia one more time. And so we should find a solution to cover, because he have to be in security regarding the vessel, with the saliva, with the tracheostomia. So and we go for a second time surgery, and the more easy and the more obvious at that time was a latissimus dorsi flap, the second one, with a double skin paddle, internal and external layer, and with this vascular anastomosis on lateral and external carotid and internal vein. The vascularization is not so bad, even if we had an hopefully a loss in the instance of the external skin paddle, and always large orostomia, tracheostomia, and nasogastric tube, because it's always the same. And what what we have to do is to close the rostrum and to improve the function, swallowing, breathing, speech, and head position. Just a sort of a second salvage situation. And so we have a very difficult situation because we know about the depleted vascular legs. Certainly what occur in the vessel due to the embolization, a large skin flap request, and a long pedicule, of course, because we have no more vessel in the neck. And so after some staff and discussion, we decided to prepare a flap to lengthen the pedicule of a large flap before to transfer it in the neck area with distal anastomosis to avoid the first and the second problem we had before. And so we decided to go for a tight flap because we need almost a larger skin, but the vessel is too short in her hand. So we decided to use this very, very reliable radial pedicle, and we put on first time an intermediate anastomosis on the radial pedicle of this large flap, folded in itself, and waiting for a period of around 3 weeks to have a very strong pedicle and to transfer it in security on the very the neck area, but in the inferior transversal vessels. And so 3 weeks after, we take it as a flap from on the radial pedicle, and we try to close by folding it inside and outside around the plate with a bypass, not a bypass, but we go like a tunnel on the skin, like you can see here, to reach the inferior cervical vessels, and it works. And here you have just the post-op picture with this large edema, but very large. I invite you to see the big surface of the flap, because as usual on the secondary with X-ray, etc., it's decreased a lot. And yeah, the first the picture certainly 1 week after with the tube and the tracheostomy, which is closed, so it began more and more functional. And here we have the 2 years result with a complete functional rehabilitation, except the morphologic, of course. And he always at that time, because he always came and say, "Oh, can you do something for the mismatch and for the color match and for the stuff?" But I always refuse. Perhaps I'm fair, but he's still alive. So we are even if we think about palliative surgery, it was possible and a good choice for him. And but the adventure behind the embolization is very severe, and we everybody in the department remind about these cases, because it was terrible for him and for us too. Thank you.
Oh, very, very nice. The excellent result in a very, very challenging case. Do we have any questions from any of our panelists or in the chat?
I have a question.
Yes, please.
No, if possible. Just congratulations, Sylvie, for you and your team. Very, very challenging case. Just a question: did you remove the reconstruction plate at the end, or you use it as a guide for your reconstruction? And did you ever use the internal mammary vessel for your reconstruction, especially in the lower neck, in depleted neck vessels case?
For the first question, for this patient, usually we change the plate. We keep it. If we decided to go one more time, and usually it's on secondary or thirdly or etc., we go for a second soft tissue. It's really because of the fact that we thought that we are on salvage surgery. If not, we go for fibula flap. But at that time, we cannot hope it was a salvage. So we change the plate, but we still take the plate because, as you see, his chin is in forward position, and without plate, it's lateral or backward, and he cannot eat after that. We thought so, but of course, it's critical because usually on those plates go outside after some years. Not for him, perhaps because we have a so big flap that we change that. And for the mammary vessels, it's very rare, but we already use it. Of course, you always go down and down and down, but in France or with our radiotherapy team, usually you can find this very low cervical transversal branch. We are not irradiated, and so but you have just to of course we prepare before surgery. We prepare for both here and we have a large a large field to in case, because in those secondary surgery you have always to have in mind a second plan B, of course. Because if not, it's always challenging. You never know what you will find.
I was not referring on to this case, but to the previous. Yeah, when I saw the previous case, I thought, maybe the case was
but because we chose jejunal flap, it cannot be. Also, you have a sort of geometric, very difficult jejunal flap, because jejunal flap is a terminal vascularization. And it's very, very, when it works, it's perfect, but it you should be sure. And mammary is too far away. Thank you.
Great. That was it's a very creative solution to a very challenging problem. There's a question in the chat that I was also thinking the same thing I wanted to ask. In this case, instead of doing this, the transfer to the arm temporarily to increase the vessel length, why not use like a saphenous vein graft to create a veno-arterial loop? Do you ever use that, or do you have a preference of why one versus the other?
Yeah, we ever use it in other cases, and certainly in the I remember from fibula mandibular reconstruction on one side. There is no fibula at that time. It was the iliac crescent, but we use a loop because we would like to reach the opposite side. But it was a secondary cases. But just because there is there was a complete mandibulectomy, one hemimandibulectomy, but there is also radiotherapy, but we have nothing before on the vessel. And what is very difficult with this man, the second way, is that we know about the quality of the vessel inside the neck, and we try to imagine something even in external position, and could that is to say a pedicle strong enough to support the retraction, the edema, the hemodynamic variation. So something we have been tasted before on the arm, and with the loops, or it's not so. The pedicle is frail too. And so it was our last solution. So we have to be secure.
Very good. Excellent. All right. So Dr. Tessalon, if you can stop sharing your screen, we'll go to Dr. Wax's case next. He's going to discuss a part of the oropharynx that sometimes is overlooked, a case that we usually only see once in a while that can seem very straightforward, but can have very surprising outcomes. So Dr. Wax is going to talk about posterior pharyngeal wall tumors.
Okay, the standard, can everybody see my screen? Okay, great. I'm going to tailor and do this a little bit differently than the previous speakers. I'm not going to talk for very long. I'm going to ask for some opinions from our panelists to just see what their thoughts are. We have a limited time, so if I cut you off, I apologize now, but I'd like to get as many diverse opinions in what could be the controversial what can be controversial here. So I have no disclosures. If you want to come to Oregon and run the Hood to Coast with us, I will get you a t-shirt and a great experience. Posterior wall tumors are hypopharyngeal tumors. The hypopharynx makes about 3 to 5% of all head and neck cancers. It's relatively rare. Posterior wall tumors are even less from that percentage. So the opportunity to see posterior wall tumors of a limited nature is probably very small in most of our hands. This just demonstrates a normal posterior wall, and here you can see a very limited posterior wall tumor. And I'm only going to deal with relatively small T1, T2 tumors in this setting. So the management of these types of tumors is, as usual in most of our head and neck cancers, either with radiation, chemoradiation, or with surgery or some combination of that. The problem with these particular tumors is that the posterior pharynx is essential in providing protection for the airway and for allowing a normal airway and for allowing for swallowing and for a normal voice. So if you have a abnormality, you can get aspiration, you can get airway obstruction, interfere with your ability to eat and drink, and can certainly interfere with your voice. The outcomes of this particular tumor, it is rare, so it's very hard to get large series. And so most of the literature is anecdotal and with small numbers. This is a series, obviously, as a surgeon that likes to do this and reconstruct them, I've picked the best of the best. So this is a series, 10 patients reconstructed with radial forearm flaps. Almost all of them got post-op chemo or radiation plus or minus chemo. All of them in this series, the trachs were removed and they were all eating and drinking enough to maintain their weight after surgery. I would say in our experience, this is probably the exception to the rule. We don't see our results as good, but most of the time you can get excellent local regional control in these patients. And what you're left with is how do you maximize their rehabilitation? And when you want to maximize their rehabilitation, what is it that we're looking for? We're looking to get these patients to be able to swallow so that they can get back to maintaining their weight on oral. We want them not to be aspirating because you're putting an adynamic, asensate lump of tissue back there. You want them to have a good airway so that they don't need a tracheotomy. And then you want to have them have voice. And this is sort of the real things of what we want to do. So what are our options? And I'm only going to talk from a surgical perspective. Well, you can do nothing. So you can send them to the radiation guy. You can put up a split thickness skin graft. You could put up a local flap. You could put up a free flap. And I think it depends on what your flavor is. So here is just a little example of this is a T2 posterior pharyngeal wall tumor. Your prevertebral fascia is intact. It looks like you're coming out to the sides, but when you do this as a when you do your laryngoscopy on this patient, you can see that that there is a nice margin laterally. So this tumor really ends over here, and this is just a crater in the middle. So your lateral margins look like they're going to be pretty easy, and it doesn't go down far enough into the oropharyngeal inlet. So you're going to be able to sew or do whatever it is that you're going to do down here. And so I would go to the panelists and I would ask, is this something that you would approach from surgery, or would you radiate this? And I'll go with Hadi first, because Well, you're Canadian, so you're going to radiate this, of course.
Absolutely.
We both trained in the same places. So.
No, I'm from Edmonton. We don't radiate anything. My experience, Mark, is very similar to you. I think our radiation oncologists tell us that posterior pharyngeal wall they're not really comfortable with because they can't quite get the margin around it, at least. The small ones I will resect transorally or robotically, but the large ones, my experience is very poor with regards to swallowing. With regards to the larynx, they seem to function well, but I haven't been able to get them to swallow whenever I reconstructed with a forearm. So for this person, I would offer her the two choices, whether it's chemoradiotherapy or surgery followed by radiation therapy. Our hit rate for surgery and chemoradiotherapy is about 50-50. So about 50% of these patients would go for surgery first, as opposed to chemoradiotherapy.
Sylvia, what would you do? I think you're muted.
Yeah. I think we should go for pluridisciplinarity decision, and I suspect that the irradiation will be choice, even if we assume the consequences, if I should say. But I think that in France they will go for irradiation first.
Okay.
But yeah.
So let's just say that the radiation oncologists are all at a meeting and won't be home. They're not going to be home for a while, or the patient really wants to go for surgical resection.
Yeah. The forearm flap.
Yeah, so you'd use a forearm flap. So
sure.
let's how would you approach this this tumor? Would you do this robotically? Would you do this transorally? Would you do this? What's your technical approach here? Why don't we go with Armando?
Yeah, in this case, the temptation is to use the robot for the excision, and I would be scared about the possibility of leaving some major vessel exposed. Because in general, I will not try to reconstruct that defect. So my aim would be to remove the lesion transorally using the robot and not to reconstruct anything. Of course, if this is happening, you should cover this vessel at least in my opinion in that particular region. So the answer is I would go for surgery, for transoral robotic surgery without reconstruction.
Okay, having I guess trained in the previous area, we would probably approach this with a transhyoid, like a suprahyoid or an infrahyoid approach, and a lateral pharyngotomy through a transcervical approach. Well, what about reconstruction? I think the robot, you can leave these and let them granulate. Would you there's a variety of different options here. This is your lateral pharyngotomy. Would you put in a skin graft on the prevertebral fascia, radial forearm, possibly, fascia lata? What about you, Peter?
Well, in a small defect, I would, favor what Armando was saying, try to do it transoral with robot and leave it to granulate in. But if this one looks like it's gonna be a little bit bigger, I would go for a forearm, but I would take the skin off of it and do fascia only and try to let it mucosalize over, try to keep it as thin as possible, because I think the biggest problem with these is even a little bit too much bulk is too much and they're not going to swallow because it's a big insensate piece of tissue. So that would probably be what I'd favor.
Anybody have any experience with the Cleveland Clinic Mike Fritz tensor fascia lata pre-flap?
No.
No.
Not me.
What would you think?
What would I reconstruct with? I think
Yeah.
it's very similar. If it's really small and we did a transoral, I would not do anything if I can. The main problem here is that when you resect the whole posterior pharyngeal wall, it's the function of it is to clear any residue. So you get a lot of residue left over and how they aspirate. And the main problem is you resected all the nerves to the area. So they function very, very poorly no matter what you put in there. I put in a form because a lot of our patients will be undergoing chemoradiotherapy after. But I'll be very honest with the panel. I've never been able to get them to swallow. They function well. We decannulate them, but they're G-tube dependent with the big defects like this. And I do approach them through lateral pharyngeal wall and transhyoid, depending on how low they are. If they're pretty high, I can go transoral and transmidline approach if they're in the oropharynx.
Do you think that your results, I am identical to you. I never get them to swallow. And what I'm wondering is it because you've got large soft tissue, so it just feeds everything? Or if we started to use this thinner, was it Peter or someone that said deepithelialize them? If we use this thinner fascia lata, would that make things better, or they're just doomed?
I think when I look in there, the first 6 months, the forearm is really swollen, but then the forearm kind of deteriorates and you lose a lot of the bulk. So I don't think long-term the bulk is an issue for them. I think it's just the mechanics of what's happening in the phase of swallowing. I'm happy to try a very thin flap. Next time I'll try the tensor fascia lata.
I think I used up my time.
I think another option is in these cases would be I like very much the idea of the tensor fascia lata. Usually when I have to reconstruct just mucosal defect, so without skin reconstruction, I use the vastus lateralis myofascial free flap with a very small muscular component and try to preserve as much as possible the fascia lata over the muscle. And yes, and after a few months, you have a complete reabsorption of the muscular component.
That's great. Very, very challenging case, type of tumor. And, same thing. I've got a few of these patients in my practice, the ones I've used forearms for, no swallowing. I've had a couple that I've used TORs for, and I didn't reconstruct them, and they swallow. They don't need a G-tube, but they're swallowing. It's not perfect, but it's as best as I've seen. So I think that if it's small enough and you can leave it, that's the ideal situation. One of our audience members also asked about using a supraclavicular artery island flap. I think it would be very similar to a forearm, just a regional flap instead of a free flap.
Yeah.
So, yeah, sorry, Mark, anything else you want to add?
No, just that this is me trying to get up to the top of Mount Hood. This is my fellow hoping that I don't make it so that they can take over and do all the free flaps. So
Excellent.
Nice, that's awesome. So next we have Dr. Golashinsky from Poznań in Poland, and he will be talking about a case involving a transoral resection of an oropharyngeal cancer. So please, Dr. Golashinsky, go ahead and start your presentation.
Good morning, everybody. Thanks for giving me the opportunity to present our case. And we selected the one case and oropharyngeal reconstruction. And our patients it was a male and 60 years of age. Is from the history. No drinker, no smoker, suffered from throat pain for several months. And the main problem, he was with the eating solid foods, with the PSS classification is the established like the diet 40 at the presentation. And the patients had the very typical history. He was treated by GP a couple of weeks by antibiotics, and because it's not improving his health, he was referred to the cancer center. And you can see the presentation of the tumor. The tumor is the oropharynx, is on the left side, is involved the tonsil cancer, tonsil, palatine tonsil on the left side, and the also at the part of the palate. And we start the evaluation of the clinical evaluation, and we consider that we have the left tonsillar ulceration, and the tumor is diameter was 3 centimeters, and also with the soft palate infiltration, and the clinically the base of the tongue is free from disease, and no neck nodes palpable on presentation. And we took the biopsy during the panendoscopy and the histopathology reports, squamous cell carcinoma, P16 negative and HPV DNA negative. And you can see now is the imaging, the evaluation in the CT, and on the left side, you can see the tumor and the tonsil, and we also, here is the border of the tumor, and the base of the tongue is the free, is only the touch of this, is of the anatomical sites region. And we also have the reports, radiological report, and tumor invading left tonsillar fossa with contrast enhancement, diameter 33 to 24 to 30 millimeters, and tumor invading palatotonsillar and palatopharyngeal arch, and also the slight infiltration, the soft palate in 10 millimeter deep, and no base of the tongue and posterior pharyngeal wall infiltration, and no metastatic lymph nodes. And on the basis of the radiological staging is T2 and O left tonsillar cancer. And also we performed the MRI examination. You can see this is the tumor and the report. This is another scan and also the diffusion. And the report, radiological is strong contrast enhancement in the left tonsillar fossa. Tumor mass is 27, 35, and 44 millimeters. And tumor infiltrates glossotonsillar sulcus and the base of the tongue with only touch without any infiltration. And lateral tumor reaches pterygoid muscles and submandibular gland without infiltration, and no metastatic lymph nodes. And the radiologic evaluation after the MRI is T3 and 0 tumor. And the chest CT scan free from metastasis, and also the ultrasound abdomen free from metastasis. And the decision of the multidisciplinary during the multidisciplinary meeting, we offer the patients primary radiochemotherapy, but patients refuse the radiochemotherapy. The preferences was a surgical treatment, and our decision was made to proceed with transoral surgery and elective unilateral neck dissection and oropharyngeal reconstruction with radial foramen free flap. And you can see some of the pictures during the resection, transoral of the tumor. And this is the bed after the removing of the tumor. And we use, I mentioned the radial foramen flap for reconstruction, and the clinical outcome and final histopathological report is left tonsillar squamous cell carcinoma, G2 P16 negative, surgical margin lateral 2 millimeter to 10 millimeter, deep margin 3 millimeter, no metastatic lymph nodes. The patient is a good conditions, was a good condition. Is he have to be able to drink the water 7 days following the surgery and to return to oral feeding after the 14 days following the surgery. And the decision, the multidisciplinary, was the selection for the patients for the adjuvant radiotherapy, and she received the 64 grade. And after this treatment, the patients returned to solid diet, and his speech was understandable, and patient is quite happy. And you can see the evaluation of the performance scale in the diet: 100 speech 75, global score 4, and composite score 75. Thank you very much.
Oh, excellent. Thank you very much for your presentation. I have a couple questions, if you will. First one is, in Poland, is it very common for patients with P16 negative oropharyngeal cancer to undergo surgery, or is chemotherapy more common? Chemoradiotherapy, sorry.
And it depends of the advance of the disease, and we have the evaluation of the P16 and also in the genetic evaluation of the DNA, and it depends of the also the patient's preference, but the most of the patients and the first line is chemoradiation. Yeah, is the first line of treatment. And the second line, like in this case, when the patients refuse the chemoradiation treatment, is the another option was surgery with reconstruction, followed by adjuvant radiotherapy.
Very good. And in transoral cases, I think in this case it was very obvious that the patient would need reconstruction because of the amount of soft palate that was removed. But do you have a threshold where you will reconstruct a transoral case versus you will let it heal by secondary intention?
I think it depends on the size of the tumor, of course, and about the advance of the tumor, but the healing for the secondary healing for is, I think, if you have the white bed after the removing, is difficult for the patients, and also it is not quite good after when you evaluation the quality of life, about the communication, about the eating. And in my opinion, and in our department, we would like to perform the reconstruction if it's possible, if it is a good conditions to perform this kind of the surgery, and because it's the general status of the patients improving much better. Compared to the secondary healing.
Very good. In many cases, using transoral robotic surgery or TLM, if the defect doesn't require a reconstruction, a lot of people will do prophylactic ligation of branches of the external carotid artery. In a case like this where you have a reconstruction, is that something you would consider? Do you do anything like that? To sort of mitigate any potential hemorrhage post-operatively? It's probably not as big of a deal when it's reconstructed, but just curious if you do anything like that.
Yeah, I understand your point of view. In this case, for example, because we perform also the elective neck dissection on the left side, we ligated of the external branch of the carotid artery, because is the neck was opened. Yeah, it's very easy to perform, and also always you have the protection of your procedure when you operate transoral. But and also we have the opportunity to operate using the Da Vinci system, the TORS. And for example, if the, for example, the tumor is T1 or T2, but it's only really the palatine tonsil, is the ligation is not required. Yeah, it's because it's the we can very carefully take care about the bleeding during the surgery, thanks to the very good visualization and a lot of option to ligate the vessels.
Oh, perfect. Well, thank you so much for joining us today. We really appreciate it, and thank you for your wonderful presentation.
Thank you very much. All the best for all of you. Thank you. Thank you.
Thank you. We may end up going a few minutes over, but hopefully people will want to stay. We have another excellent case with Haiti Cycli. We'll present one on a total soft palate defect. And you can go ahead and take over the screen.
Armando, I hope I can answer some of your questions with this presentation. So Peter, Matthew, and Jeremy, thank you for inviting me. It's a pleasure to be with you, and wonderful to see you all again. Nothing to disclose. So this is a case of a 54-year-old gentleman that presented with a large tonsil and soft palate tumor that was P16 negative related to smoking and drinking. At our tumor board, the decision was to go ahead with primary surgery followed by RT with the addition of chemotherapy if needed. And this is the defect that he ended up with, which is a total soft palate defect. And he had ended up with about 1 centimeter of the base of tongue gone, and a total lateral wall defect. The posterior pharyngeal wall, we had to resect about 1/4 of it on the ipsilateral side, but it's all still there. So when we look at our experience of reconstructing soft palate and reconstructing oropharynx, whenever we get over the 25% palatal defect, that's when we start getting the hypernasality. And it's a real problem for these patients, even though the swallowing, as Armando was saying, it's not a problem for them, except for nasal regurgitation, but the hypernasality is a real problem. And you can see the two ways that we measure hypernasality, and all of our patients go for pre-op functional outcomes, post-operative functional outcomes, and post-RT functional outcomes, where we measure these things. We measure it through nasalance, which is the balance of nasal airflow as compared to oral airflow. And we measure it with VPO, which is a surrogate measure of the opening of the back of the nose. And you can see right after 25% palatal defect, they start getting real hypernasalance. And why is that a problem? Well, we did another study. And what we did is we recorded these patients' voices, and we let naive listeners listen to them. This is just listening to the voice of the patients. They're all very intelligent, capable people, but with the bias that we have for voice and the balance in our nasal and oral cavity components of speech generation, they rated these patients based on their voice alone. They rated them as dumb, lazy, unemployable, drunk, unattractive, weak, and unreliable. This is not seeing the patient's face or not interacting with the patients, just listening to their voice. So it's a real problem when we reconstruct soft palate. So the goals of reconstruction for soft palate for me are to eliminate the adynamic portion as much as possible. It's the opening in the back that's not very dynamic that will give them the hypernasalance. We all know that we cannot reconstruct the fine motor movement of the soft palate, so trying to neurotize it in any way is not going to be helpful. But an opening of a 20 millimeters squared, a static opening of 20 millimeters squared, will give us that balance that we need. We need to maintain the eustachian tube function. We also need to maintain nasal patency. So we have a paradigm of reconstructing the more than half soft palate reconstruction. You see on the bottom there, we use what's called a soft palate insufficiency repair modification of the radial form, and our favorite arm for that, for reconstruction for that, is soft palate. Again, is forearm. Because it's so thin and pliable, and we can manipulate it and fabricate it in a fashion that I'm going to show you. So what we do is basically recreate, like Armand was saying, recreate the look of the soft palate, not the function. We can't recreate the function. So we use a form to reline the nasal aspect of the soft palate and the oral aspect of the soft palate. And then the edge of it is the rolled edge. So it's not the free edge, but rather the rolled edge. And I'm going to go to a cadaver demonstration because you see it a lot better. So you can see that we've reconstructed the soft palate here. This is the rolled edge of the soft palate. Half of it is up in the nasal cavity and half of it is in the oral cavity. And we have to eliminate this adynamic portion. Otherwise, they're going to get hypernasality. So the way we do that is we make a cut on the rolled edge, and then split that flap just just to the fat. Split that into a flap that's oral and nasal. That's the forearm. And then we use a pharyngeal flap. So we use we cut the posterior pharyngeal wall. If the reconstruction comes across with the forearm, we'll still cut the forearm and create those two flaps. So we create a superior pharyngeal flap and an inferior pharyngeal flap, as you see here. And then we start closing the flap. So the nasal aspect of the soft palate is close to the superior pharyngeal flap. You can see me approximating them here and closing them here. And then the oral aspect is close to the inferior pharyngeal flap. And you can see we close that there. And the only opening is the feeding tube. And luckily, the feeding tube is about 20 millimeters squared in an opening. This is what it looks like in real life. Again, this is a complete closure of the insufficient or the soft palate insufficiency repair right here. Typical form. All the flaps here are submucosal or subcuticular and just through the skin, so the whole flap actually survives quite well. More importantly, when you look at some of the parameters of nasalence and some of the parameters of VPO, which suggest hypernasality or normal nasal balance, the normal line is on the bottom, and you see all the patients that, again, fairly large number, Mark, 10. Very small number, but again, you can see that the patients that had almost 75%, 100% or greater than half of the soft palate reconstructed, they all go back into that normal balance. So their nasalence is within normal limits, their VPO is within normal limits, and most importantly, their intelligibility is within normal limits. And again, the most important thing is people don't think all these horrible things that they thought of when they listened to their voice. Swallowing is never an issue with soft palate. I think even without a soft palate, you can probably swallow quite well with regurgitation. About 20% of our patients will require us to open the opening into the oropharynx, between the oropharynx and the nasopharynx, because they experience some nasal blockage. And I do that as an outpatient with a laser. It works quite well. And that's my presentation. Thanks again.
Excellent. That was very good. Very good. Thank you very much. Are there any questions for Dr. Cycli?
Hattie, I wondered, so were the majority of your patients non-irradiated?
50-50. So even with radiated patients, and Mark, I know you've seen this, when you radiate the soft palate, they may not work anyway. It just pulls forward and it becomes a non-functioning soft palate. So this does work on radiated salvage patients also.
Yeah, my only other comment would be, I used to also fold the radial forearm flap to give you that nasopharyngeal lining, and I no longer do that. I just leave the raw surface, the raw undersurface with the pedicle exposed in the nose or the nasopharynx, and it just mucosalizes, and it's not a problem in terms of thrombosis or infection.
Good to know. I've always been scared of leaving the pedicle open, but I'll try that next time. If it fails, I'm going to send them to you.
Well, I wish I could say I thought of it, but I think my fellow did it one time when I wasn't in the room and it worked. So now I'm going to take credit for it.
Sounds good.
Clearly, as I understand, is a sort of a pharyngoplasty, like for cleft palate surgery.
Yep.
It's a sort of the same, because you use this pharyngoplasty on the foreign flap to have more tension on the flap and the dynamic possibility of the mucosa, the pharyngeal mucosa. It's a good idea.
That's exactly right. It's just you got to close that adynamic portion. If you keep that adynamic portion open, they'll never have proper speech balance.
Of course, it's exactly like for insufficiency in cleft palate surgery.
Yep. Absolutely.
Great.
Excellent.
Just a comment. Yeah, I read with great interest the paper. Yeah, just few days ago, because I wanted to be updated for this presentation. So very interesting. One aspect I think it may be considered for the quantification of the nasopharyngeal insufficiencies and in general for functional outcomes is also the lateral attachment of the flap. I told you just because usually when we perform transoral robotic surgery, we usually remove even half of the soft palate, and laterally we just remove the superior constrictor muscle, and we leave it like this, and we have a normal retraction without nasopharyngeal insufficiencies, good swallowing, pretty nice voice. So so just a comment to tell that probably we need also to take into consideration if we remove or not the medial pterygoid muscle, and how lateral is our resection, in order to also further correctly evaluate the kind of reconstruction we should use.
Absolutely, and I think for less than half, and with robotic surgery, you'll notice that you don't actually go superiorly and take a lot of the soft palate. We take the lower edge of the soft palate, and we leave about 1 centimeter on most of us. Will leave about 1 centimeter of soft palate, especially if we're doing a tonsil resection. It's that part that you can actually get the posterior pharyngeal wall flap up to it. But when you resect it all the way to bone, like both our cases, it's very hard to use pharyngeal flaps to close, and that's why this technique works a little bit better in that sense. And this technique will help you even if you go lateral, because it'll cover that lateral wall.
Thank you very much.
Well, that was great. If I could get 2 minutes, I just wanted to follow up on that, because that was an interesting point that Armando was making about the pharyngeal flaps. I have a very short case, just wanted to see what the panelist ideas would be in a case like this. So very similar, slightly smaller, but similar patient. This is a 74-year-old guy who kept having epistaxis, and eventually went to one of our graduates who figured out the epistaxis actually coming from his uvula. And in the clinic, this is what it looked like through the mouth and through the nasopharynx. So it looks like it's a T2N0. We biopsied HPV positive squame of the uvula. But he was not the easiest patient.
Peter,
yeah.
Let me stop sharing.
Yeah, you weren't sharing there. So okay, you're
I'm
on
not sharing.
now. You are.
Am
now.
I sharing?
I was stupid and kept sharing, so my apologies.
Oh, I'm so sorry. Okay, real quick. This is what he looks like intraoral through the nasal pharynx. You guys can see that?
Yep.
Perfect. Okay, so that's where his nasal bleeds are coming from. And so it's the diagnosis is he has a T2N0 P16 positive squame of the uvula. Not the easiest guy to deal with. He, first of all, says he never wants radiation therapy because he's seen the damage it has done to a friend of his. So he only wants surgery, but I can't cut on his face. I can't use a free flap. I have to fix this some other way. And it took some negotiating, but he agreed to shave for surgery. So to be a bit creative in this one. So this is what he looks like at the time of surgery. This is the exposure. My plan for the resection is going to be something like this. So the entire soft palate. This is the resection. That's the defect. So no free flap. From the panelists, any ideas of what you might do for something like this? Other than an obturator, if you have a really good prosthodontist, I've seen it work before, but I don't have a good prosthodontist anymore for that sort of thing.
Peter, is the posterior pharyngeal wall okay?
Yes, posterior pharyngeal wall, oops, is just fine right there.
It's not ideal, but you could do a posterior pharyngeal wall flap, superiorly based, bring it up and sew it between the two edges of the mucosa, and then let the anterior surface granulate.
Kind of like
very much like a cleft palate repair.
yes, I know exactly what you're talking about, like a posterior pharyngeal wall flap. That's an option.
I would
Now,
agree.
in this case,
I'd agree with Hadi. I probably would do that as a first stage. And then I think Netterville sort of did that modification of what Hadi did with the feeding tube. He would leave two lateral ports, just big enough to fit a feeding tube on either side. My success rate with that is, I'm going to say 50-50. It's probably worse. I just think it's so dynamic that they tend to tear it. But it's probably the least invasive and the most benign way to do that. If it didn't work, you could probably do a like a palatal flap based on one of the sphenopalatines coming out, swing that around, and again do the same thing, just leave them a small lateral port on one side.
very good. I was bringing this up because Armando was talking about doing some pharyngeal flaps, and in him there was so much laxity in the lateral pharyngeal wall mucosa that we could actually make a tube out of it by dissecting the constrictors away from the prevertebral fascia and essentially sewing it together like a primary closure laryngectomy. And then you have this surface here, which initially I was thinking maybe a FAM flap or something, but I did what Mark had suggested and used a palatal island flap for that to cover that up. And so this is it being rotated in, and that's what it looked like at the end. And I used some Integra on his palate because, again, he refused skin graft, can't take any tissue from somewhere else. So, Integra actually works pretty well for this sort of thing. Did that, put a bolster on it. And then pathologically, he didn't need any radiation. So he would have refused it anyways, but this is good for him. At 6 weeks, 3 months. And then this is more recent. It looks like I put a larynx in the back of his throat. And I didn't expect it to look this way, but it actually turned out just fine. And, in my case series of 1, it worked out good. 100% feeding tube independence, good voice. And I think Mark would be proud. His mustache was preserved.
Yes.
And he doesn't snore.
Exactly. And there's no snoring. That's right. All right. Well, yeah, sorry for going a little bit over time. Let me see if we have any other questions that we can get to since we have everyone here. Yeah, people are asking about posterior pharyngeal wall flaps for the soft palate, superior FAM, another option from one of the residents in Vermont. Bilateral FAM flaps also from Bianca in Italy. Hi, Bianca. I know I can't see you, but it's good to hear from you. A scarf flap, I don't know what that is, but that sounds like something that would go well in Canada. And submental as well, an option from Jeremy. I've certainly used a thin submental to do a palate reconstruction before, unilateral, but some good options there. So anyway, thank you very much. I'd really like to thank our colleagues from around North America and especially from Europe. Hopefully we'll all be able to see each other in person this summer in Montreal. I'd love to see everybody there. And, thank you so much for joining us today.
Thank you, Peter.
Thanks, Peter. Great.
Thank you very much. Thank you very much.
Thanks, guys. Take care.